Welcome to the May Nashville Meet Me Call. We are honored to have Dr. Ken Minkoff, who is a community psychiatrist, addiction psychiatrist, and Vice President of ZiaPartners, a behavioral health system consultation firm in Tucson, Arizona. Dr. Minkoff will be discussing co-occurring mental health and substance use disorders. He has extensive expertise on the design and development of integrated systems and services for people with co-occurring mental health and substance use disorders and other complex health and human service needs. He also contributed to the recently released Co-occurring Disorders chapter of the American Society for Addiction Medicine Patient Placement Criteria, 4th edition. We appreciate him co-authoring the 2019 Technical Assistance Coalition paper titled Integrated Systems and Services for People with Co-occurring Mental Health and Substance Use Conditions, What's Known, What's New, and What's Now. Dr. Minkoff, we appreciate our partnership. Thank you for being here. Please go ahead.
Thank you, Brian. I appreciate our partnership as well. And I want to shout out to the many of you that I know and have worked with over the years. And I'm delighted for this opportunity to present this material today. So there's a lot of stuff here, and I'm going to be moving through it very quickly, so we'll have some time for dialogue. My most important goal is to help you guys become aware of what the best approach is for changing your ability to serve people with co-occurring mental health and substance conditions throughout your service delivery system, what I call changing the world and designing your system at every level to be about the needs and hopes of people with co-occurring conditions who are everywhere throughout your system. But I want to focus on kind of laying out sort of the basic approaches and then getting into a discussion about how you can make it easier for yourselves to do this over time, and also to avoid some of the things that people fall into very commonly that seem like good ideas, but wind up often making it more difficult and getting in the way. So next slide. So this is an opportune moment for readdressing this issue. As some of you know, there was a lot of funding for implementing integrated mental health and substance services back in the mid-aughts for about a 10-year period. There were COSIG grants, about 19 states were funded. We worked with a lot of them back then. And SAMHSA set up a co-occurring center of excellence that lasted for about 6 years. And then that all stopped as if we had figured this all out and solved the problem and people had created departments of behavioral health and the world was all wonderful. But as you know, things really had not fully developed on the delivery of integrated services. And so there's a lot more work to do. And we've been focusing a lot over the years on integrating health and behavioral health, but now we're starting to realize that we have to pay more attention to the fact that the behavioral health part, the mental health and substance stuff, is not as integrated as it needs to be. And this is ongoing work over time. So there are a lot of resources that you have available and some new opportunities. One of them is the TA paper that Brian mentioned. And there's a lot of material in it. There's background references on a lot of things I'm going to say. And if at the end you decide to assign someone or you decide yourself to really look at that detail and see how it applies, that will be a home run as far as I'm concerned. In addition, there are some new things. So one of them is that since the 988 implementation, and all of you guys are working on crisis services, SAMHSA has made it clear that crisis service and crisis system development is integrated right from the get-go, starting with 988, mobile crisis centers, the whole 9 yards. So this is putting a greater push on developing integrated services throughout the continuum if the crisis services are going to be that way. The ASAM criteria, which just came out last fall, the new version, the 4th edition, puts much more detail into describing how all substance disorder services need to be co-occurring capable and describes how to do that as a base expectation across all programs within base resources, as well as providing information about where to fit more specialized, what they call co-occurring enhanced services into the continuum. But it's much stronger than the previous version. The opioid epidemic has made us more aware of the co-occurringness within the opioid population, the opioid use disorder population. And most states have been trying to figure out how to manage an infusion of opioid settlement funds, which is an available resource that can be used to invest in this. Those of you that are working on CCBHCs also know that CCBHC is a vehicle for looking at both mental health and substance inside the CCBHCs, and potentially a funding stream to support capacity development within CCBHCs. And then, a lot of the integration work on the health side, like through the Comprehensive Health Integration Framework, is building on some of the work that we did years ago on that I'm going to share with you on how to do an integrated system for mental health and substance. Next slide. So the starting place is to look at this from your system's perspective as a population, and we call it the complexity challenge. And we're talking about any person of any age with any combination of any mental health issue, including trauma, and any substance or addictive issue, including gambling or even nicotine dependence, if you wish. We also talk about co-occurring families, which are very important in children's services in particular, where one member has one kind of issue, like a child with an emotional disturbance, and another member has another kind of issue, like family members, caregivers, siblings with substance use issues. So the family system needs an integrated approach. These folks are everywhere throughout the system. They often have many more things going on than mental health and substance only. They show up in all kinds of other systems: housing, criminal justice, child welfare, et cetera, et cetera, et cetera. They tend to cost the system more money in all areas, and they tend to have poor outcomes in multiple domains, including being among the folks who are most likely to die. And if our job is to design our system to be about the people who need us, naturally we would be thinking, if you look through your entire state system, that at every door in every setting, people with co-occurring needs would be clearly prioritized for attention. But what we tend to experience is that in so many places, at so many levels, those folks are not experienced as priorities, and they may even be experienced as misfits. So, and when folks are experienced as misfits, it's often hard for them and hard for the people serving them to feel really happy when they show up. And so one of the starting places is just thinking about, how do we start designing our entire system so that when people with co-occurring needs show up who are having poor outcomes and high costs, that everybody is really happy and welcome them. The next thing. The next slide is that one of the things we want to start just by foundationally welcoming people in is not just like, we'll tolerate you or we have to deal with you, but we want to inspire you with hope. And by showing up here, even when we don't know how to fix you, which is likely, we want you to feel more hopeful that by virtue of having met us, we're going to be working with you over time to help you with all your issues to have the best life you possibly can. And we want to have that be not just a clinical thing, but the way that we design the outcome that our services want to produce. We want to be in the welcoming and hope business for the people who need us the most. Next slide. So we start asking ourselves, how well organized are we so the people who need us the most are welcomed and inspired when they show up at every part of the delivery system that we're operating as a state? Next slide. And here's the kicker, okay? Because it's not that these folks are uncommon. In fact, just the opposite. The big driver for thinking about this throughout the system is that not only are these folks doing poorly, there are lots of them. So the key element for thinking about how we want to design our system is to remember that co-occurringness is an expectation, not an exception, pretty much everywhere we look. And so that if our job is to design our system to be about the people who need us, then we have to think about how all the services that we provide under the auspice of our state behavioral health authority are designed to welcome, engage, inspire, and provide integrated help to the people with co-occurring mental health and substance use disorders, as well as the other complex conditions they bring along. Next slide. So in the framework that I've been developed, 25 years ago, and developed in a SAMHSA publication in 1998, and have been teaching about working on implementing for all these many decades. The basic thing to think about is what we call the comprehensive continuous integrated system of care, but I don't really care if you ever memorize that. But the key element is that what this means is that every program in your system needs to be designed as a co-occurring program to be helping to serve the people with co-occurring needs that are no doubt already there. And all those nice things, welcoming, hopeful, strength-based, recovery-oriented, all that's lovely. And the key word is that every program is a co-occurring program that is what we call co-occurring capable. That not only that, every person providing help needs to know how to be a co-occurring helper. And all those nice things as well inside the programs that they're in. And I call this a program of recovery for systems. And the key thing I want to emphasize for you guys is that, first of all, it's inspiring. We're talking about welcoming and hopeful systems, and recovery is about hope. But it's also something that involves creating a steady improvement process, just like for individuals, that goes on over time. And many states that we worked with have done some great work for a period of years, and then they don't anchor it sufficiently, so it starts to unravel. Because the next person comes along and says, why are we putting mental health and substance together? They're separate. Let's unravel what we did. So thinking about how do you build something so that your system is improving over the long haul, and doing it slowly and steadily in a way that is really engaging and empowering throughout the system is part of what you can do to help your system go down this path. Next. So the way to think about a co-occurring capable program is you think about every single program or service in your system, and you think, back in the beginning, when we first invented this program and designed the service instructions and regulations and everything else, if we knew then what we know now about how much co-occurringness was going to be happening in that program, and if we knew then what is known now, which is all written out in that TA paper, and I'm going to go over very quickly, about how we actually could be designed inside this particular program to be helpful to those people using best practice interventions. What would we do to build that in within the base resources in line with the mission of that program? And in your whole system, every program is a co-occurring program, but every program will have a different job based on what it starts to be doing. Is it residential substance treatment? Is it adult case management, or, for people with serious mental illness? Is it children's school-based outreach? Whatever it is. And the people or families with co-occurring needs who are already there. Next. At the same time, every person providing care needs to have clear instructions about how to deliver appropriate interventions for the people in front of them, what we call co-occurring competence. And this is not about people having multiple degrees, licenses, or certifications. I mean, if they want to have those, it's great. But whether you have 1 license, 2 licenses, 6, or none, and sometimes the best people at doing this are peers, are frontline case managers, because they've never been trained not to just be helpful. Everybody can become a helpful partner within their job at their level of training or certification to know how to be helpful and hopeful to the people with co-occurring needs that are already in front of them. Next slide. So is this a vision that you might like? And then you go, how do we get there? Next slide. So this is a transformational process. And so sitting up at the top of a state, you want to think, this is not something we just do to everybody. This is something we try to leverage everybody to be doing. And we're doing it to be helpful to them because they're already serving those people. They're just feeling frustrated because they don't know how to do it well, and they don't have the right infrastructure to support them. They're often working around a lot of things that have been put in place that seem to get in. So we want to look at our system and think, how do we engage all of our partners over time? You don't have to solve this tomorrow, in making progress toward being co-occurring capable inside whatever it is that we're doing with whatever resource base we have. And that means the State Behavioral Health Authority and our partners, however your state is constructed, regions, CSBs, ADAMS boards, county systems, Medicaid managed care organizations, all of the tools that you have can be lined up to work with your providers to support every program moving toward a common vision. Next. So, and then how do we do this clinically? And then one of the things that really I've learned over the years makes this really hard for everyone is that they don't make it simple. So the more that I've done this for decades, the more that I've come to understand that the simpler you can make it, the better it works for everybody. The biggest thing that gets in the way is us. We start reaching out for some latest, greatest evidence-based practice with some fancy jargon, and we feel like we have to implement that thing throughout the whole system, and it gets very convoluted. I'm not saying there aren't some very cool specific program models that people can do, but you have to do something to scale. And so when we originally did this, and you look at all the research, you look at what is it that actually helps people at the level of interventions, and how can we build those interventions so that people do the stuff that works and don't do stuff that doesn't work, step by step throughout the system. Next. Now, the way to think about this transformational process is as a big quality improvement partnership through the system. And customer-oriented continuous quality improvement from an organizational lens is what I call the recovery process for systems. Big vision. We want to help our customers, all of our customers at all different levels. We're going to do it in a step-by-step, measurable, organized way over time. But we're not just going to do it in a tiny project. We're going to leverage improvement throughout the system. And so we're going to create partnerships at different levels, at different domains. Examples like in some of the New York counties that have developed co-occurring system of care committees, and they get everybody around the table and they use that to be the kind of the 12-step meeting for the change in the system. But you build that at different levels, you know, within your intermediary structure. And each program and each part of the system has its own 12-step program of recovery, which helps them understand what their job is to do, regardless of what everybody else does. You develop change agents and champions at different levels to kind of do some bottom-up change, working with the top-down change, so it happens at different things, and you make progress in small measurable steps over time. And the focus of sustainability is to anchor the process and the content in an ongoing way into your bureaucracy. So the more that this stuff is anchored, okay, so that it's routine and not just special co-occurring policies, but that all your policies are aware that there are co-occurring people served at the other end. The more solid this goes and the longer it lasts and the longer the process of improvement can continue. And one of the key variables in this is to hold everybody in their mind what I call the serenity prayer of system change, the serenity to accept the things you cannot change, which is everybody else, the courage to change the things you can in your own domain, and the wisdom to know the difference. Next slide. So they're tools. I mean, we have a whole toolkit. Many of you have already licensed them and may not be using them, but you have them. Some of you licensed them a long time ago and don't have the updated, better versions, so please ask. We also have 12 steps for programs and 12 steps for staff that I'll send out afterward. And some of you are using other co-occurring capability tools like the DDCAT and DDMUT, which is just fine. So, but there are tools that can be used at different levels of your system to measure where you are and help guide you. That's the important thing. Next. And then there's all kinds of stuff. Once you get the idea that co-occurring is an expectation, you can build this into all kinds of things. I'm leaving this in, just so you know it's there. And there's the next slide as well. Next slide. And next slide. There's all kinds of slides at the end of the set that you'll get that we don't have time to get to. Now, what are the basic clinical principles that guide everybody at the level of simplicity? Next. Well, the first one is we want everybody, when they see people with co-occurring needs, to welcome them. And that's involved a specific proactive customer service. And you want to really establish a foundation that just because people are complicated, it's especially important to make sure that you say welcoming things to them and don't be unwelcoming. And then we start to look at removing access barriers and welcome the opportunity to identify these folks in our data system. So as a state organization, we have the data we need to manage our improvement. This is a key phrase. If we're not counting you as a system, it's because we're designed as if you didn't count. And one of your markers is to look at how well you collect accurate data on who's co-occurring, not combining diagnoses, not seeing who's dually registered, but just how many co-occurring people, yes or no, are in any domain. And does that match what clinically are actually way undercounting? So this is an early marker. Next, what are we welcoming them into? We're welcoming them into relationships. And the cornerstone of success for people with co-occurring needs is to be engaged in relationships that are empathic, hopeful, integrated, and strength-based, okay? Where we work on the things that people are doing right in small steps to help them do it better over an extended period. And it commonly takes years for people to be successful in small steps. So we have to stop feeling like failures if we haven't fixed them in a few weeks or months, and stop thinking somehow they're going to complete treatment or whatever that means and be done. But we have to work on the fact that, people are making progress. They may slip back, okay? And they are recurrently successful, and we're helping everybody make small steps of progress over time. Next. Within our system, as I said earlier, all programs are co-occurring capable, but they have different jobs. And sorting in your system, that, like your adult mental health system will be working with a lot of people who have SPMI, who have co-occurring substance issues that they're not interested in dealing with. So that's your job. Let's do it well, and let's learn how to help those people make slow progress over time. Your substance programs are going to be dealing with lots of people with co-occurring mental health needs, most of whom are not SPMI, some of them will be. And we want to help them address those mental health issues inside the substance world, just as ASAM criteria now guide us. And one of the things we want to do is to have our programs work as helpful partners with each other. And one thing to ask yourself is your mental health system designed to regard your substance providers as priority clients or support for consultation, education, and in-reach, and vice versa? Or do they operate in parallel as if they're not there to be helpful to each other? Next slide. Next slide. Yeah. So, no, I go back one. Thank you. So the best intervention is to make small steps of progress for each issue at the same time. So instead of thinking somehow we're supposed to know how to fix people, it's much easier if wherever people are, we're focused on helping them make that next step of progress. And that includes medication for when it's appropriate, including mental health and substance, as well as psychosocial interventions for all issues, including other complexities like housing, for which there is no medication to fix your housing. And so it's the best next small step for each at the same time. Next. One of the ways we help identify the next step for each issue is by recognizing that individuals and families are in different stages of change for different issues. And success is appropriately measured by interventions that are stage matched and outcomes that are stage matched for each issue. Have we built that into our instruction set, particularly in the mental health side, so that people understand that it may take a long time to make progress, But if it takes you 6 months to move somebody from pre-contemplation to contemplation, that's a good thing. That's success. And we need to keep at it. Next. And finally, when we're helping people, we need to help them to learn the skills they need to succeed. And so there's a lot of stuff about concrete skill building. This is less about what services people attend than what we're doing within the services to teach people what they need. And there are lots of available skill manuals that have been around for a while that people tend not to use. And I put one in there, which I think is particularly cool because it's so simple to use. Okay, next. So this is the summary of what we want to achieve. Within every program, we want the people with co-occurring needs who come to experience welcoming, empathy, hope, connect to continuous integrated recovery and support partnerships, addressing multiple issues, and providing adequately supported, adequately rewarded, strength-based, skill-based, stage-matched, community-based learning for each issue so they can move toward the goals of a happy life and recovery for both issues that they are capable of achieving and deserve to get. So how do we do this? Next. So now we get to the do's and don'ts, okay? So, obviously you're not going to absorb all of this quickly, but let me just lay out some of this. Next. So system visioning and leadership, okay? It's important to start by making it clear that you want to move toward the vision of universal co-occurring capability. And the message you're saying is every one of you, whatever you do, fund, serve, co-occurring people are at the other end and they're a priority. And if you're not organized within what you're doing to know how to be most helpful to them with the best practice interventions, then you have an opportunity to improve and they'll do better and so will you. And our scarce resources will be used more efficiently. So let's all get together and let's talk about articulating this vision. Where do we start? We don't have to fix it tomorrow. We're starting with all of us engaging in quality improvement together. And we can start by looking at our current baseline and finding out what is it we're already doing well. What are some of the places where we need to improve? And we're not going to improve everything at once. So let's pick some priorities and start there. And some of the priorities are welcoming basic instructions for integrated service delivery within our policies and procedures and funding instructions, and collecting better information about who the co-occurring people actually are. And we start developing a change structure throughout the system. Don't think that because you have combined a pile of funding, you've assigned it to a managed care organization, you've created an integrated org chart, that integrated services are going to drop out the other end. Okay, next. Okay, so expect all programs to make progress toward co-occurring capable for QI process, building it into whatever QI expectations you have. Okay, and this is something that needs to be ongoing. And, some states, people will do the tools and send them in and nothing happens. So you need to actually have some system in place internally to be helping people make progress and continuing to make progress, through the usual formats of learning communities and technical assistance and consultation. But it's more important to have continuity in small steps over time than think like you're going to achieve perfection in a year or two. So just slow down and make it something that you can sustain. And things to focus on are better data collection. As you get better information filtering up through the state, it tends to tie to better service delivery. And it's integrated teamwork, cross-consultation partnerships in each community, rather than maximizing referrals back and forth, because neither of the clients don't necessarily, sometimes that's appropriate, but the default for people to get what they need in a single door and have fewer people fall through the cracks, and not to have everybody with two issues need two funding streams, which would make us go even more broke. All programs should be able to become co-occurring capable within their current licensure. So start thinking, how does our existing mental health program license define that co-occurring capability is part of what you do. Same for our substance license. Don't say what we're going to do is create special co-occurring licenses so some of you can have co-occurring licenses and everybody else will somehow not have that, because that actually sets people backwards and start thinking that only some of us have the job of co-occurringness when all of us will be dealing with co-occurring people. There are reasons to have administratively, to manage somebody who wants to operate a co-located service and they have one building license. That's a different thing. That's not co-occurring service delivery. That's just an integrated administrative process. Next. Do get very clear that you can deliver co-occurring services in every single funding you have. Mental health block grant can support co-occurring service. Substance block grant can support co-occurring capable service. Each Medicaid service code can have instructions for co-occurring service, okay? That needs to be defined, explained, so people know how to document it. They know what's appropriate to do. And everyone overseeing and auditing has instructions for knowing what the right kind of integrated service looks like. And it's not just a referral. The vast majority of co-occurring capable service can happen within your existing base rates. A lot of states immediately go down the path of deciding they're going to pay extra for co-occurring, which is a huge funding trap. Okay, and then you can create an administrative nightmare for yourself by asking people to add like service modifiers for every code for the co-occurring so they get the advance rate. And if you're not paying your providers enough, you can pay them more. I'm all for it. But everybody should be able to do co-occurring capable services. This is defined within their base rate. For those small subset of programs that are co-occurring enhanced, you can pay extra if you need to. Some of them that's necessary. But start with co-capable, because if you build up your base, you won't need as many specialized services. Okay, and then single funding stream. Braiding funding is useful in strategically specific ways, but if you say every time we do co-occurring, we have to combine two funding streams and bring in two different clinicians from different areas, and it gets way complicated in a hurry. And it may be a great idea in the moment, but you're automatically shrinking your ability to scale this. Next. Now, workforce development, okay? Co-occurring competency is not something we're doing to torture you, people. You're already serving co-occurring people. Our job as a state, with all of our partners, is to help you have more fun and more success by giving you the right tools. We may have failed by not giving you the right instructions and the right practice supports. Then we're going to change that. Okay, but this is about helping you be more successful and having more fun. So this starts with not making this rocket science complicated. Like, in order to be co-occurring capable, competent as a clinician, you have to memorize the entire DSM and know every detail about every substance and every neurotransmitter. Nobody knows that, including me. Okay, so make it simple. There are simple ways for people to be helpful, and let's line them up and really help you to practice and get supported in learning how to do it with the co-occurring people in your setting that you're currently dealing with, and routinely support that on a regular basis. Develop co-occurring competency instructions, and if you can, work with your licensing boards, as we did years ago in New Mexico, to provide simple instructions for what a co-occurring scope of practice for each singly licensed clinician should look like. And we actually wrote some articles about how to do that. That makes life a lot simpler. Incorporate this into the core training for peers, so that peers, whatever their starting place is, are knowing they're going to be working with people with co-occurring issues and they have some guidance for how to do it. Don't fall into the training trap. The training trap means we're going to send everybody to a training and then they're going to be trained and that's all we need to do. Or we're going to send them to get credentialed and then they're get credentialed and that's what they need to do. Sometimes people go to trainings and what they learn is, this was so horrible that I never want to work with this population. Okay. And training alone is the evidence-based worst practice for competency development. So the training has to be mostly lined up with the practice supports. And it's not your job as a state to do that. It's your job as a state to provide the infrastructure that helps the programs develop their own staff and support their own staff so they can take care of the clients and have everybody have a better time. Okay. So next slide. So what will be your next step? Now, at the end, I have a whole bunch of slides about things you can apply this kind of co-occurring thinking to, and you can take a look at them at leisure and ask me questions. You know, send me emails if you have questions. I'm happy to do that. But for now, let's just have a bit of a discussion. Thank you for listening. Hope this was helpful. Okay, we're not going to go through this. I mean, you can just flip them through. Thanks. All kinds of stuff.
Dr. Minkoff, this was phenomenal. Thank you so much for being here. Your last slide actually is the question that has come in. If a state was going to change one thing tomorrow to become more co-occurring capable, what would that be?
It's very hard to just change one thing. So what I would get back is have the courage to say out loud that we are going to be, so we are recognizing that there are co-occurring individuals and families in every part of our delivery system, okay? And we're going to establish that the vision clearly is that everyone is going to become co-occurring capable. So just saying that one thing, this is our direction. And then you say, we're going to develop, we want to work in partnership with everybody to help you identify where you are, your current baseline, and find some things to improve. And we're going to provide you training and technical assistance to improve. And we're going to begin to provide our funders opportunity to develop for how you can use each funding stream to deliver co-occurring services. So it's a leadership and visioning and direction. And just starting there, that helps you to decide. So what are our next steps? And are we bold enough to say that out loud to people in partnership so that we're all going to work together in that direction? Part of the thing that is hard to resist as a state leader is your providers will say, okay, we'll do something, pay me more. And then you say things like, I would love to pay you more. And we're going to pay you guys as much as we can. But no matter what our base rate is, you're going to have co-occurring people. And our job is to help you learn how to do the best co-occurring work you can so that you can become the provider you love to be with the co-occurring people you already have.
Great. No, thank you. Yeah, I love that answer. I love the inspiration that you weave throughout your, that vision that it's about the people, that we're serving. Question, do you have suggestions for encouraging mental health and substance use providers to work more collaboratively? So if they're currently siloed, how can they start to build that relationship? Mm-hmm.
Yeah, so there's, again, think of it as a multi-layered approach, okay? So one of the things that's important in state systems, is that in most places, the substance providers tend to feel less than the mental health providers. It's just historical. And they hold the state, responsible for it, for things that your predecessors may have done years back. So you want to be very sensitive to that. And in bringing this together, you're saying this is about helping everybody do a better job within the resources and the population that you have. And we're going to sit around the table individually. Everybody has the ability to improve, no matter what anybody else does. Because getting people focused on their own internal improvement before they go saying, I can't do anything until you help me, is very important not to create unnecessary tension. You're bringing in your constituent groups and you're treating them all as expecting partners, saying, we're wanting to help all of you be successful. And, you know, to the extent that people say they're under-resourced, you say, I'm all for helping you get more resources, but whether you get more, you know, like I said earlier. Now, the big thing to focus on in this area of helpfulness is to say, it would be great, as I said earlier, if the mental health providers looked at the substance providers and the, you know, everything the substance providers do as priority clients. So very often substance providers have these very complicated people. They have all these mental health issues and they try to refer for mental health help and they get a lot of barriers. You know, well, how do we know they're really SPMI? We can only take them if they meet this criteria. As if they were not part of the same system, right? As if they were not the same clients that we all, as if they're from some other planet, you know, and they have to beg for admission. So if you say instead, we're going to set up instructions so that we're in every geography, mental health and substance act as partners, meaning that the mental health world treats the substance organization as a priority client. Instructions and even funding instructions for how to provide consultation and in-reach. That's very helpful. Okay, I'm here to be helpful to you and learn about you. Conversely, you know, to help the mental health clinicians stand in there with some of the difficult folks they have who are not going to be referred anywhere, and to prevent people from being referred inappropriately, you want to build the same backwards consultation help from the substance folks to the mental health folks, and you want to support that. It's much cheaper, more efficient, builds better partnerships for everybody to act like organizational partners and for staff to move around to support those partnerships so that clients are all over the place and people fighting over boundaries.
Right. Thank you. Thank you. A question came in. One of the debates for crisis stabilization is whether individuals need to be cleared medically by an emergency room before getting into a crisis stabilization program. How does this issue facilitate or create a barrier for co-occurring services?
Okay. Yeah, I know the debate, but among those of us who do crisis stuff, and I'm one of the lead authors of the roadmap for the ideal crisis system, it's not a debate. People should not need routine medical clearance before entering a crisis center, period. Okay, that's an urban myth and it's a lot of stuff. And so, if you look at what like the CRC in Tucson does, Margie Balfour, they'll talk about how they figure it out. The person's in a coma, they took an overdose, they go to the emergency room. If they, have some serious medical thing that would normally require an emergency room, then they should go there. And if they don't, you should take them. And so in terms of, co-occurring services, one of the big things is, and I've been, doing this for such a long time, but I still run into this, like, well, you're suicidal and you're intoxicated. So, and you're using substances. So we can't actually do anything until you're no longer substance involved. That's bad care. Okay, there's nothing to that. The time to start evaluating someone who's using substances and has some kind of mental health crisis is as soon as is immediately, even if they can't talk, because you want to gather collateral information. And as soon as they can carry on a conversation, you want to assess what's going on, whether it's psychosis or suicidality. It's a serious issue for that person. And the fact that they're using substances in addition doesn't make it somehow less serious. I mean, people are more likely to kill themselves when they're drunk. Doesn't mean every drunk person that says they're suicidal is serious, but you have to talk to them to figure it out. So building this so that your crisis system, because the legacy of crisis systems thinking they're in the mental health business and not the substance business is very powerful. Everybody who works in crisis for any length of time has been trained that way. So what you're doing now is changing that equation, which is why the overall substance vision is so important. Now, as soon as you start doing it at the crisis front door, then you have to think, how do we create the partnerships where we're doing it across the board? Because the crisis people will tell you, and they won't be wrong, well, if we want to hospitalize the person, they'll say, well, we're not going to take that person if they're actively using substances, because that's not our job. And of course, it is their job, right? And just like, you know, they would say, well, this person's drunk and they have cirrhosis of the liver. And so we'll wait until before we, no, you know, we're going to admit in the medical unit. So bringing everybody together and saying we're all moving in the same direction. And part of the thing I'm trying to convey to you is there is knowledge in the world to know how to do all this. It takes a lot of step-by-step detail, but it's not rocket science. It does start with changing attitudes and, you know, like this is our job, right? And if you do that in your state, you'll have a lot of folks who are already there, may be happy doing this because, you know, we've been doing this for a while. We're glad you're supporting it. And you use the ones who are better at it to help bring along the ones who are not. But the more that you make this a whole state endeavor, the less you're going to be hamstrung by the folks who want to fight back with you, because that gives the negativity ones all the power. So it's a combination of content and then change management. And it's okay to ask for help. You know, there are other places that are further along that can help you. And, you know, there are people like me and other people who know how to do stuff like this that can help you. But ask for help. And one of the things that we really would like, as I said to Brian before we started, is to just all of you go to SAMHSA and say, why do you have 1 million technical assistance centers and there is none for helping us with co-occurring stuff, co-occurring mental health and substance? Okay, we have physical health, we have criminal justice, we have all this stuff, but mental health and substance integration, you know, you think it's all fixed because we know it's not. And we need help. So,
Yeah, it makes a lot of
okay.
sense. No,
Okay, we slipped over our end time, Megan. So
that's okay. You know,
I'm-
Dr. Minkoff, this has been absolutely fascinating. And I think just an ongoing conversation. There's so many questions, so many things. I walk away, you know, just that broader picture of the expectation that who we're serving is co-occurring and the co-occurring capable. Those are things I hadn't quite heard before. So that's really helpful in terms of the
Thank you.
principles. So we hope to talk with you even more.
Good. Well, and if anybody wants to reach out to me and have a conversation, no charge, just please do. You know, I'm
Right.
happy to help you say, well, you know, here we are and wherever, and what should we do next? And, you know, that's lovely. That would be well received.
Great. Well, this has been an amazing dialogue. We will, yes, we will share the slides afterwards. And there were some questions that came in that we weren't able to get to. And if we can send those to you, Dr. Minkoff, and then we'll put them
I'll be
out.
happy to answer them to the best of my ability.
Wonderful.
Hi,
Thank you
Sherry.
so much.
Thank you. Thank you, Carrie. Oh, my buddies.
Thank you so very much. We so appreciate your time and great dialogue and presentation. We're now going to move to Aaron Walker, our policy director, to do the Washington update. Aaron.
Thanks, Megan.
Mhm.
Good day, everyone. If we go to the next slide, please. All right. Want to make sure you guys saw there's a new center of excellence. This is a new center of excellence for tobacco-free recovery. And they're having an introductory webinar coming up on June 20th at 1 p.m. Eastern. And this is to explore how to work together to end disparities in commercial tobacco use for people with behavioral health conditions. They're going to discuss how this new center of excellence is engaging with state level stakeholders, health and supportive service leaders and providers, and people with behavioral health conditions who use commercial tobacco and their families in changing policies, systems, practices, and social norms that drive the delivery of effective, accessible, evidence-based tobacco cessation interventions that meet people where they are. So you'll see a link here at the top to the actual website, and then at the bottom to be able to register for this introductory webinar. Next slide, please. And then also the next Center of Excellence for Protected Health Information, their next webinar, their upcoming webinar next week, 42 CFR Part 2 Final Rule, What You Need to Know. This is May 21st at 3 p.m. Eastern, and they will outline the recent changes to Part 2 and apply learning to common scenarios through case studies. So you'll see the link down here to register, and if there are any questions, please reach out to Michael Graziano at his email right there. Next slide, please. And then another registration opportunity, this is the 988 Communications Framework Learning Collaborative. This is through SAMHSA's 988 CSR TTAC that is hosting a 4-part virtual learning collaborative series that aims to help states, tribal nations, and territories identify priority communications needs. So leaders and decision makers in 988 Lifeline and Crisis Continuum of Care Communications will have in-depth conversations regarding successful communication strategies. Excuse me. So this series is for communication leads who are directly involved in the creation and implementation of the 988 Suicide and Crisis Lifeline communication strategies. So this includes SAMHSA grantees, states, territories, tribal nations, and community partners. The enrollment registration is open through May 21st. And you'll see the schedule set forth here beginning on June 4th and runs through September 3rd. So definitely use the link here to register at the bottom. Next slide, please. On May 8th, SAMHSA announced $46.8 million in notices of funding opportunities to promote youth mental health, grow the behavioral health workforce, improve access to culturally competent behavioral care across the country, and strengthen peer recovery and recovery support. So you'll see there's $15.4 million from the Minority Fellowship Program, $14.9 million from the cooperative agreements for the Garrett Lee Smith State Tribal Youth Suicide Prevention and Early Intervention Program, $9 million for Addiction Technology Transfer Centers cooperative agreements, $7.5 million for the National Center for Mental Health Dissemination, Implementation, and Sustainment Cooperative Agreement. And you see a link here at the bottom to the announcement. Next slide, please. The National Substance Use Mental Health Services Survey has just been released, and this is a survey of all substance use and mental health treatment facilities in the United States, its territories, in the District of Columbia, and is sponsored by SAMHSA. So this provides federal, state, and local governments, as well as the behavioral health research community, with information about the number and characteristics of public and private substance use and mental health treatment facilities nationwide. Now, this one survey is taking place of 2 surveys that have been combined for this. This was replacing the National Survey of Substance Abuse Treatment Services and the National Mental Health Services Survey. And you'll see a link here at the bottom to the survey itself. Next slide, please. SAMHSA has also released the 2022 Mental Health Client Level Data Annual Report that details the total number of clients receiving mental health treatment services in 2022 by demographics, national outcome measures, otherwise known as NOMs, top 5 mental health diagnoses for children and adults by geographic distribution. Also, the NOMs that are presented in this report include stability in housing, residential status, adult employment, as well as access to services / capacity. And you see a link here to the level data right there. Next slide, please. The Department of Health and Human Services has issued the final rule regarding Section 1557 of the Affordable Care Act. This authorizes the Secretary of the Department to promulgate regulations to implement the non-discrimination requirements of Section 1557. And it's also revising its interpretation regarding whether Medicare Part B constitutes federal financial assistance for purposes of civil rights enforcement. And additionally, it's revising provisions prohibiting discrimination on the basis of sex in regulations issued by CMS governing Medicaid and CHIP. And you see the other areas that it is revising provisions as well listed below. And you see a link here to the Federal Register. Next slide, please. On April 23rd, HHS released the 2024 National Strategy for Suicide Prevention and accompanying federal action plan. This is a collaboration between SAMHSA and CDC in partnership with the National Action Alliance for Suicide Prevention. An interagency work group comprised of over 20 agencies and 10 federal departments across the government contributed to the development of this national strategy. So at the links here, you'll see a link to the announcement itself and then a link to the strategy itself. Next slide, please. Announced on May 9th, flexibilities designed to help states and beneficiaries survive the millions of post-pandemic Medicaid eligibility renewals will continue through June 30th of 2025, extending the expiration by 1 year and providing Medicaid directors some of the stability that they've been asking for. A couple of the examples of the flexibilities include letting states renew beneficiaries coverage based on their Supplemental Nutritional Assistance Program, otherwise SNAP, or temporary assistance for needy families eligibility. Every state has adopted at least one such waiver except for Florida, and you'll see the extension of the flexibilities link here at the bottom to the CMCS informational bulletin. Next slide, please. SAMHSA has announced the publication of Saving Lives in America 988 Quality and Services Plan, which provides a blueprint to continually improve and standardize 988 suicide and crisis lifeline services across the country. The plan clarifies roles and definitions, sets forth national federal requirements across operations, data, privacy, cybersecurity, training, referrals, quality assurance, and communications. And it also emphasizes the roles of SAMHSA and the 988 Lifeline Administrator in setting national performance expectations and adherence to standards while establishing processes to approve local flexibilities in building crisis networks and systems of care. And you see a link here at the top to the actual services plan. Next slide, please. Also, SAMHSA has launched the National Training and Technical Assistance Center for Early Serious Mental Illness. This provides training and technical assistance resources and support for those providing early serious mental illness services. So state mental health authorities and programs funded by the Community Mental Health Services Block Grant, 10% set aside for early serious mental illness and clinical high risk for psychosis. Grantees can request individualized training and technical assistance services by the email here. And then you'll see links here to resources for individuals and families, providers to be able to access the newsletter and the treatment locator. Next slide, please. On April 22nd, CMCS issued 2 final rules ensuring access to Medicaid services, otherwise known as the Access Rule, and Medicaid and CHIP program, managed care access, finance, and quality, the managed care rule. The access rule addresses critical dimensions of access across both Medicaid, fee-for-service, and managed care delivery systems, including home and community-based services. The managed care rule strengthens standards for timely access to care in states' monitoring and enforcement efforts, enhances quality and fiscal and program integrity standards for state-directed payments, specifies the scope of in lieu of services and settings to better address health-related social needs, further specifies medical loss ratio requirements, and establishes a quality rating system for Medicaid and CHIP managed care plans. So you'll see the links up here at the top to each of the rules and the link to the fact sheet and applicability dates table to the managed care rule. Next slide, please. Our next upcoming SAMHSA-sponsored webinar, Building Hope, A Journey Through Crisis Residential Service, is occurring Tuesday, May 21st at 1:30 Eastern. And this is hosted by the National Council for Mental Wellbeing in partnership with NASHBID. This is the second session in the 4-part crisis stabilization learning series that's sponsored by Samsung. Presenters listed here below are from Giant Steps and D.D. Hirsch Mental Health Services that will explore an efficient, cost-effective, and innovative model for crisis residential services, including peer respites. And you see a link here at the bottom to register. And next slide. Thank you guys so much, and I'll pass it back to Megan.
Aaron, thank you so much. Dr. Minkoff, thank you so much. This has been enlightening.